Hello, this is Dr. Mark Kontos with daily coverage here at the ACOS Winter Meeting in Aspen, Colorado. And with me today is John Kanellopoulos, and Dr. Kanellopoulos is one of the world's experts on corneal cross-linking. And we're going to chat a little bit about what the newest things are that are happening for him in that area. John, thanks for joining me today. I really appreciate you taking the time to talk with me. It's good to see you again. Tell me a little bit about what's happening new for you in cross-linking.
All right, thank you, Mark. Thanks so much for having me. It's really a pleasure to be here in Aspen. We have been, actually you're right, we have been working with cross-linking in Europe over the last 12 years and have really excelled the indications, the technology, and it's almost sad when I moved to my New York City office not to have this technology FDA approved and available, but it's going to be soon. We're expecting probably FDA approval for Avidro within the next few months. As far as our European work, we're working mainly on three different directions. The mainstay direction is using cross-linking for ectasias, cornea melt situations, and infection. So these are more of the therapeutic applications. And the latest technology that we use is that provides higher fluence, pulsation of the treatment to allow oxygen to fill in the cornea. This may be a venue to propagate better and deeper cross-linking. And I foresee in the future, when the technology becomes available, and I think we're almost there, to do pattern cross-linking. So not cross-link the whole cornea as a uniform tissue in order to stabilize it biomechanically, but borrow some of the knowledge that other parts of medicine have, such as orthopedics and vascular surgery, to reinforce tissues that should have elasticity. You can reinforce them in a pattern way, and that actually gives more strength long term.
That's an interesting concept that you just mentioned there, because I wonder sometimes, you know, when we do cross-linking, we're cross-linking such a large, wide area, and I wonder if we would get sometimes more effect if we could be more focal in terms of the cross-linking treatment itself. And so maybe that's kind of an area where, in a way, what you're talking about there, and how you might be able to really control what the cornea actually does.
It's interesting that you mentioned that, because that's applying to the third area that we're working on. Looking back into our experience with cross-linking, and every surgeon that has performed cross-linking will relate to this. For many years we've been talking about disease regression when we're seeing corneas flattening, ectatic corneas flattening, about 1 or 2 diopters. It is a recent thought over the last few years that we're not actually looking at disease regression. We're seeing a refractive byproduct that comes in with collagen cross-linking. And as you mentioned, if you apply cross-linking in a succinct, smaller area, this may cause a more significant refractive change. And this, in the hands of Avidro and 2 excellent investigators, B.J. Dupes from Cleveland Clinic Foundation and Satish Harikar, a physicist, have brought us with the new Avidro technology to the level to be able to do so. So we have in Europe since summer of 2013 been working with technology that applies specific patterns on the cornea that are very high fluence, 3 to 4 times the fluence we're used to with the classic protocols. So instead of 5 to 5.5 joules, we're applying 15 to 25 joules of total energy in the cornea, and we're seeing effective refractive corrections of small refractive errors, both myopic, hyperopic, and toric. So this is extremely exciting stuff.
Yeah, absolutely, because, you know, of course, we like to see stabilization of the cornea and preventing continuation of the disease, but the patient wants to see better. And so if there's a way that we can be able to do that, both of those things at the same time, then that's a real benefit and a real win-win situation.
Exactly, and if this proves, we have 7-month data. We actually presented the 3-month interim data at the American Academy, and we have a couple of publications in the works that show, to my amazement, significant stability. Of course, 7 months is not long enough to put a stamp on it, but this would not only address ectatic corneas, but it could potentially address small refractive errors. And it's really a non-procedure intervention. This is a procedure where you put drops in the cornea for 10 minutes, apply the light, the UV light, for 5 to 10 minutes. Patient walks out, they don't feel anything, and you get a dramatic refractive correction of up to 2.5 diopters. So this may apply to all that huge pool of patients that are either timid to do a refractive surgery. They may get the comment, well, it's a small refractive error, it's not really worth doing a PRK or a LASIK procedure. And also the retreatments for both LASIK cases that have regressed a little bit and or cataract surgery cases that have small refractive errors left over.
Yeah, exciting stuff, John. Really lots to look forward to. I really look forward to seeing the work that you do in future. And thanks again for visiting with us.
Oh, sure. Thanks for having me.